But when would you start Diclexis, Gary, or any of the three of you, on a Gravida 1, coming in, first pregnancy, she's missed her first period, and she's starting to have little twinges of nausea. She's starting to feel. That was the first thing that made you think she was pregnant. When would you consider the need to start medication?
Okay, in light of full disclosure, I'm so damn old that I prescribe Bendectin. So I'm biased because as a first and second year resident, I had Bendectin and I prescribed it, and I know what the results were in prescribing it. A couple of things about our study design, which again, we needed to do a study that was acceptable to the FDA. So I think one of the reasons that perhaps we didn't show a greater effect in the clinical trial relative to the puke score was that we didn't start it as early as I would Dr. Hale in a patient that's coming to me. So again, if I have somebody that's come in and they're telling me they're having symptoms of morning sickness, nausea and vomiting of pregnancy, I'm going to have the discussion with them and say, we've got options. You can do the diet, etc. But if this is troubling you or if it accelerates, we have a medication that's got proven safety and proven efficacy. So I would offer it early. Earlier than the clinical trial actually allowed us to give the drug. Again, part of this is clinical bias from. And the other, back to what Giddy said, the woman who's been admitted in previous pregnancy or scared to death of it, this is not what FDA has approved this drug for, but we all understand therapeutic drift, right? That woman I'm going to offer the drug to before she gets ill.
Yeah, I would support Gary's notion. There is this tendency, take the crackers and do this and that. You have to do that anyway. You have to find out with her what is more likely to cause her stimulation and so on. But just remember, all of us, when we have the beginning of a migraine and we say, let's wait, and then 2-3 days we cannot function, I personally, as a pharmacologist, believe you should treat earlier. Don't let symptoms increase on you. Often it's a vicious cycle. And we're talking drug A, so why are you preventing her from the benefit from stopping it? If 75% of our patients go to work and then come home to do more work, what is our right to tell us suffer a little bit more? What's the logic in it? Would you do the same for men? Probably not. So I'm very, after talking 20 years to thousands of women with MVP, I will not wait. I'll optimize all our other stuff, food and stuff, orders, sleeping, very important. But I will not avoid her for another couple of days till she's really on 4, and then she may need even hospitalization because she has acetone in the urine. So I say early.
Jennifer?
No, I would agree with that. I treat the patient as soon as she tells me the conservative measures have failed and she's feeling sick, treat her. I mean, I think Dr. Hankins can go into the detail, but the first step is to give her 2 tablets at night, and then the next day see how she does during the day. But if she doesn't do well in the day, she then takes 2 tablets at night and 1 the next morning. And then she waits another day, and if it's still not good in the afternoon, she takes 2 at night, 1 in the morning and 1 in the afternoon. And but I understand that that's a lower dose than the over-the-counter that we've been using, and we're seeing some very obese women these days, and perhaps we could use even more if necessary. You said up to 8 tablets a day in Canada?
Yeah, I should be careful here. The label said 4 a day, and we should stick to it. But experience in Canada show that as physicians gained more experience and did not see side effects, we published several papers on the safety of up to 12 a day. It's not that we gave them to patients, but we thought it's important to let the community know that nothing happened, and really nothing. And as Jennifer said, 30% of our patients in America and Canada now are obese. Another 30% are overweight. So some of the doses become a little bit homeopathic now. We really talking about much larger human beings. And I think we'll have to change our whole approach. However, I have to caution all of us. FDA approved 4 a day based on a study, randomized trial. I have no doubt that if we gave higher dose, we will see more effect. I also have no doubt that the Canadian experience show that there's no side effects. But that will have to wait. That FDA will have to agree to. And that will have to be more trials. So I wouldn't recommend anyone to start now more than 4. And for most women, the 4 will do well.
Question is, how many pills would you prescribe on a prescription, and what is going to be the cost of the medication?
I believe a bottle will be 100 tablets. Am I correct? Yeah. The bottle will have 100, which will cover, if she needs 4 a day, about 20 days, which makes sense. I cannot talk to the price because I never discussed it, but I really do not know.
It depends on the gestational age at which you're starting to treat her. If she's already sick at 5 or 6 weeks, you can anticipate that it's going to peak at 9 weeks and not really be gone much before 12 weeks. And if you think she's going to need 4 a day, you'd have to calculate that. In the study, the average age they started was 9 weeks, and you treated them for, what, 3 weeks?
More than we think, women go into the second trimester, and some of them the whole way. We just meta-analyzed all the information around the world. I was surprised.
Yeah.
More than 25% of women with NVP continue to have it in the second trimester. I thought it's much less.
No, it's not. That's
But
right.
relative to what I would write for the bottle of 100, and I'd give her refills. If she's doing great, she doesn't need to get it refilled. If she feels that she still having symptoms, I mean, we might as well make it as easy for both the woman as well as for the provider as we can.
A question is, the patient calls you. You've seen her for her first or second prenatal visit, and she's now starting to get nausea. She's now at 8 to 10 weeks, and she's suddenly starting to get nausea. Would you consider just ordering the prescription, or would she have to come in to see you?
I have the luxury of working with directly with 3 fantastic nurse practitioners. So, the patients generally prefer the nurse practitioners over me until it comes time for surgery or something like that. So they would call and talk to the patient, and if it's no fever, no chills, the things Jennifer addressed, then we would be very comfortable in calling in a prescription or doing an e-script for them. We wouldn't make them come in for an exam.
We talk to hundreds and sometimes thousands of women with NVP a year, NVP, with nausea and vomiting. So we had a woman who occluded her shunt as a reason, it was called NVP by a physician. We had several pancreatitis, we had several appendicitis. If you see enough, you will have the differential diagnosis. So how much you can trust your stuff on those calls is very personal. But do remember, when 80% of women have a condition, some of them will have something else. And we see it the same in the winter with children with pneumonia, with flu. Everyone have flu, but some of them have pneumonia and so on. So, yeah, very, very experienced nurse practitioners can help, but do remember in the back of your brain that it could be something else. And per definition, if it starts after 12 weeks, it's not NVP by the book. It does not mean that she may not be hormonally different from all the rest, but be much more suspicious that it's something else.
That 60% of people will be over it by 12 weeks and 90% by 20 weeks.
That's right.
I have a question over there.
My congratulations for all the conference, and I know very well the panel. Professor Jennifer Nibble came to Buenos Aires 2 decades ago, and I was a resident, and I listened to her with a master in a master class about uterine inhibitors, and I remember that now.
Well, thank you.
After this, I want to say something. I want to ask you something. I think that the nausea and vomiting is the first challenge to the relationship between gynecologist and patient. The gynecologist must tell her how to eat, at what time she is waking up, at what time she's going to bed, what kind of work she make, or how is her relationship with the husband or in the work, because all these kind of symptoms I think are an origin in the environment of the women. And in the second step, we go to the pharmacological treatment. I'm not all agree about to give the pharmacological treatment first before the symptoms appears, because I think that the doctor must ask a lot of questions before to give a treatment. The first question is, why not to give counseling and to be near the patient, and then the pharmacological treatment?
I think. Correct me if I'm wrong, but I think what he said was that that was for patients who'd had previous pregnancies with very bad nausea and vomiting in pregnancy and difficult to control, and that in the subsequent pregnancy you would try to start it earlier. Is that correct?
No, thanks for making it. First of all, your point is very important. When we interviewed the women who call us, they say that they don't trust their physicians because they are not nice to them. They don't take it seriously. When you're about to die from vomiting and feeling so terrible, the worst thing is when people don't take you seriously. By the way, they say the same about partners, about employers, so it's not just a physician. But your point is well taken. But what I find is physicians, because of the litigious atmosphere, are postponing drug therapy and not asking the question. So it's not that they do all the rest. It's just fear of a drug. Here you have a drug that there's no reason to fear anymore. So I don't think we should wait too much after you acknowledge the other things. If she tells you that she's the CEO of Google in her city and she has to be on her feet from 7 a.m. to 7 p.m. and control 1,200 employees, I don't think she can bear these symptoms very easily. And that's part of the discussion. But I agree with you. I think in general, women tell us that we do not take this condition, we trivialize it. But your point is very well taken.
Could I make one other point on that? If I heard correctly, it was also that it's category A now, but we know FDA has put drugs out and then something happens and they're either pulled, the side effects aren't picked up. That won't happen because of the duration and quality of the data with this drug. If there was ever a drug with enough information to categorically say it is A, it is this one. Not just limb reduction defects, but when Dr. Lamb looked at every defect, there's not a single defect that shows up anywhere close to a statistical significance. Now, some of the importance of this is Dr. Lamb, when he conducted his studies, was appointed by the court as the person to be basically advocating for the aggrieved party or injured party. So the court appointed him not to defend the drug, not to defend the drug company, but to get to the truth. And again, if we ever have a drug that is solidly A and will never change, it is diclegis.
Yes, one last question.
I'm curious about if before this drug, since we don't have the drug quite yet, when you're dosing with Bendectin and Unisom, or not Bendectin, when Unisom and B6, how do you dose? I first heard Dr. Nibel talk about this back in, I think, 1986 in Atlanta at a conference on outpatient outpatient obstetrics, and
I have to stop traveling so much.
Someone asked this question, and I grew up with Bendectin, and she said, "Well, I use Bendectin," and she said she used.
The trouble is that B6 in a lot of stores only comes in 50 milligram tablets, and for practical reasons, I told them to break it in half, and that's 25 milligrams. But that's 2.5 times what's in Bendectin or diclegis. But it's not harmful to take a little extra vitamin B6. The Unisom comes as 25 milligram tablets, so it's close. It's one tablet at night. It's 25 milligrams instead of 20. and a half in the morning and a half in the afternoon is how we usually did it.
The only problem, of course, these two are short-acting. They're absorbed quickly, and the effect will be very quickly. The gimmick that came with bendectin and now with Decleges, that you take it in the evening where most women feel okay, more or less, and it gives you the protection in the morning when most women are not okay. So that's the beauty here, which we saw in our studies and with many, many thousands of Canadian women. So it's not to say that these two will not work. But first, they are not approved by FDA because none of the companies care to do that. And second, they don't have the delayed relief, which is a big, big bonus.
Well, thank you very much. I want to thank the panel for their presentations, and I hope you did learn something from this.